that coming up, Angela?
That's there, Sandra. Yeah, perfect. Thank you. Okay, I think we can kick off, Sandra, because it's 11:30 now. Good morning, everybody, and welcome to today's webinar, when we're going to be looking at patient involvement in the incident management and the open disclosure process. This is very much in keeping with the World Health theme for Patient Safety Day this year, and with our open disclosure themed week theme for last week as well, when we're talking about the importance of patient involvement and elevating the voice of patients in relation to not only their own care, but in relation to their own safety as well. And just before we start, I wanted to say a note of thanks to everybody who engaged in our open disclosure themed week last week. The response across the system was just amazing. And we were so encouraged and so grateful for all the really important promotional events and training events that took place across the system last week. And we will be writing up a summary of that, of those events that did happen. So we're very grateful to you in raising awareness last week of this really important topic that is open disclosure, incident management and patient safety. So just some housekeeping before we move into our today's speaker. Just to say that this session is being recorded today, and you can leave your video turned off and remain muted throughout the presentation. And when you join the presentation, you can listen to the webinar over the computer, but sound may be better if you dial in over the phone, and the number is there on the screen, and it'll be in the chat there as well again for you. Just to let you know that today's session is accredited. There are 2 CPD points awarded by the RCPI and 2 CEUs by the Nursing and Midwifery Board of Ireland. And these do apply to attending the live webinar. And if you do want a certificate of attendance for today's webinar, then please email the Open Disclosure Office at opendisclosure.office@hsc.ie. I just want to apologise to people. We were unable to secure an ISL interpreter for today, so my apologies in advance to anybody who is affected by that. You can access closed captions on your screen, and that's text that will appear on your screen to reflect what is being said by the presenter during the webinar. And to enable this function on your device, please click on Show Captions on the bottom left of your screen, and you'll see on the screen there how you can do that. So again, my apologies in relation to having no interpreter today. So we're delighted to pass you over now to Lorraine Schwanberg, the Assistant National Director for Incident Management, when she's going to introduce you to our today's speaker. And we're very excited about today's presentation from Professor Jane O'Hara. So over to yourself, Lorraine. Thank you.
Thank you, Angela, and just to echo that sentiment again, thank you so much for all your support and involvement during the Open Disclosure Week. It was a huge success, and thank you to our team as well, who played a huge part in that. I'm delighted today to have Professor Jane O'Hara here. I think she knows that we are big fans of her work, and I think just going through her bio, you'll understand why we're so interested in her work and how we can learn from her research and our team's research. So Jane O'Hara is a professor of healthcare quality and safety, and she's based within the School of Healthcare in the University of Leeds. Since 2019, she has led out on a National Institute for Health and Care Research program of work, which was aimed at co-designing and testing new processes for involving and engaging families in investigations and learning responses following healthcare safety events. And we'll be putting in a few links into the chat as well, so you can access those. She also leads the NIHR funded response study, which seeks to evaluate the implementation of the new patient safety incident response framework, which is the new English model for undertaking incident reviews over there. So similar to our incident management framework. And she's also the Deputy Director of the Yorkshire Quality and Safety Research Group, and jointly leads a team entitled Safer Systems, Cultures and Practices with Professor Coran McRae within the NIHR Yorkshire and Humber Patient Safety Research collaboration. And she's also a visiting professor at the Share Centre for Resilience in Healthcare at the University of Stavanger in Norway, and an expert advisor on the infected blood inquiry led by Sir Brian Langstoff. So I'll hand over to Jana, who will share her slides. Thank you.
Thank you. It's always a little bit cringy, isn't it, when you hear a long bio? I should have made it shorter. Can you see those slides? Are they coming up for you, Lorraine?
Yeah, perfect. Yeah. Thank you.
Brilliant. Okay, well, thank you, Lorraine, for the invite to talk to you today. It's a real pleasure to come and talk to you a little bit about some of the work that we've been doing over in Yorkshire, as it actually, I'm going to say it's England, but we like to call it the Republic of Yorkshire. And it's really, really timely, I think, given the focus that you guys have got on open disclosure in the last few weeks and months. But so what I hope to do today, I think, is to talk to you a little bit about our work in the context of how we might move beyond just open disclosure, beyond openness and transparency being something that only happens at the beginning of an incident investigation. Actually, how do we as organisations ensure that patients and families are listened to, that they're learned from, and that they have a as positive an experience as they might be able to of investigations or learning responses. And the reason that I think that we should do this, I will go into some of those reasons, but one of the main things that we've come to learn from this programme of work called the Learn Together programme is that if we don't enact these sorts of principles of openness and transparency beyond disclosure, that actually we can cause further harm as a result of the processes that follow incident identification and investigation. So I think it's a really timely opportunity to discuss some of the things that we've learnt and hopefully provoke some discussion with the brilliant panel that Lorraine has brought together today. So, okay, some background to the work that we have done. So I started my patient safety journey in 2010. That was my first role. I had worked in applied psychology before that, but Rebecca Lawton, who some of you might know her work, she employed me over at the Bradford Institute for Health Research, and I started a portfolio of work more generally around how we engage and involve patients and families in patient safety initiatives. And one of the first pieces of work that we did was a large study where we tried to understand what patients and families could tell us about safety and how that information could be used to improve safety. And so from that big work, that big program of work, what we really established, I think, certainly within the UK, was that patients and families could tell us an awful lot about safety. They could tell us about things that had happened. They could tell us about things that might make accidents and errors more likely, so things that might contribute to future harm. And in that sense, then, it sort of brought together other emergent work that was suggesting that patients really should be seen as partners in learning when something's gone wrong in healthcare. So this work really came about not just because this was an emerging problem, but because it was based on a really good understanding, I think, of the roles of patients and families in helping us support patient safety more generally. And then at the same time as we were sort of establishing this evidence, and of course there was other work that was going on internationally that was providing evidence along the same lines. Within NHS England, some legislation was brought in 2014 and enacted via the Serious Incident Framework in 2015, which obligated organisations and professionals to be open when an incident has happened that met a certain threshold. So there was an obligation to be candid, if you like, about such incidents, to enable patients and families to understand that something has happened to them, but also potentially to prompt their involvement in further subsequent processes around the management of the incidents and the investigation of those incidents. And so the duty of candour was specified within what was then the Serious Incident Framework. That was the policy that came out to guide incident management in NHS England in 2015. And it was kind of seen as the sort of minimum standard. So to be open when something has gone wrong and met a certain threshold was the bare minimum of how we should be engaging patients and families at that time. And there was a suggestion in that framework that actually patients and families should be engaged more across the incident investigation process, although very little was actually written about how that might happen. And when we started to look at this problem in 2018, we looked back at a Care Quality Commission report where they looked across a series of serious incident reports across NHS acute hospitals and reviewed the quality of those reports. And they concluded that only around 12% of the reports that they sampled actually included any clear evidence that the patients or their family had been involved further in the investigation processes. So open disclosure had happened, but actually the intention of the Serious Incident Framework, which was to suggest that good practice would be to try and involve patients and families in investigations of serious incidents, that just wasn't happening. And that was in 2016. And then a call came out in 2018 from the National Institute for Health Research, really looking at the area of improving the experience of complaints, improving the experience of investigations for patients and families. And so we started to really look at this whole landscape based on our understanding that patients and families had a really integral role to play when something has gone wrong. And so we started to try and understand what is going on within NHS within England, and we came up with a series of conclusions. So we could see that organisational learning was a key aim of investigations, obviously within the serious incident framework and more broadly within safety theory. But we also had evidence that patients and families were not routinely involved in those investigations. So we really knew that, based on our understanding of the wider role of patients and families, that actually we were really missing a key perspective in terms of understanding what had happened when something has gone wrong in healthcare. And so our hypothesis, if you like, when we were drawing together this programme of work was, you know, if we can involve patients and families in incident investigations, can we improve the learning that comes from those investigations? So fast forward to 2019, we were successful in getting nearly £1 million from the National Institute for Health and Care Research for what became a 4-year programme of work. And the aim of this work was to develop and test new processes and guidance to support the better involvement of patients and families within the serious incident investigation process. So that was what it was called at the time. We've since had a policy change and it's now called incident responses, but at the time we were specifically looking at these investigations of serious incidents, which were incidents that had met a particular threshold and needed to be formally investigated. So what did we do in the early phases? Well, we wanted to do 3 key things to really understand what was going on with respect to the involvement of patients and families within incident investigations. And the first thing we did, probably understandably, was to take a random sample of around 50 policy documents from across hospital trusts within England to understand what they said that they were doing about it. And I thought this was going to be a really dry we weren't particularly looking forward to this aspect of it. We thought it would be really boring and we'd just be looking for certain information. And actually what we saw was a huge variety of how policies are written, how patients and staff are talked about in terms of their involvement and their needs, which might arise following an incident investigation. So it became really clear that the sort of bare minimum in these policies was open disclosure. And actually for most trusts, they didn't even, within the policy, they weren't moving any further forward in terms of involvement investigation. There wasn't much mention of it. There certainly wasn't any real sense of how staff might do that, or you know, any sort of systematic approach for doing that. So we knew from that that really this was a ripe field for supporting organisations to do this better. We then also looked at the scientific literature on what was known about the experience of being involved in an incident and then the subsequent incident investigation. And we were able to draw all of that information together, and we've actually published an article there, which I can send on for those who are interested. But it really helped us understand what was currently known within the academic scientific literature around this issue. But what we really wanted to do, what was really important, was to speak to people. And so we went out and we tried to, and we were successfully able to, in fact, not just tried to, we were able to speak to 3 key groups of people. And we spoke to over 40 people across these 3 groups. The first key group obviously was patients and families who had experienced an incident investigation, and to really understand what it was like for them to have that experience of the incident, what the disclosure process was like, and and then following that, what their involvement had been or not within the investigation, and what that meant for them in terms of their experience of the full event. We were then also able to speak to staff, healthcare staff who'd been involved in an investigation. And what was really interesting for that, and I'm probably not going to talk as much about this, but it might come up in the panel discussion. What was interesting about that was actually for the investigation process itself, what we saw was a huge commonality actually in terms of some of the needs of healthcare staff and families, in terms of their needs about how to be navigated through an incident investigation, the worry, the concern, the confusion. There were many more similarities than we anticipated between those two groups of the investigation process, not the incident itself, but the investigation process. And the final group that we spoke to was investigators, and it was really important for us to speak to people who are doing the investigations, because actually what we found quite quickly was that this group is largely unknown in terms of who the people are, what their level of training is, what their level of capacity is, so the amount of time that they're able to devote to incident investigations. It was very variable, and actually there's not been a huge amount of documentation of that. So given the incidents are this cornerstone of how we manage patient safety globally, in fact, within healthcare, it struck me as strange actually that we didn't know who these people were and how they were doing this work. So it was really important for us to speak to them. And then drawing all of that information together, what we could understand then was, okay, so if we're to co-design, if we're to develop new ways of doing this, or better ways of doing this, building on people's experiences, what are the key principles that we need to make sure are there as foundational to the processes that we're developing? And so we came up with what we then called principles for meaningful involvement, and there were 10 principles. As you look across the principles, you can probably guess at many of them, and there is certainly overlap, I think, in many of these types of documents. And since we came up with these, I know in Healthcare Improvement Scotland have come up with some similar principles. We see some similar principles within the Healthcare Safety Investigation branch over within the UK. So some of them aren't terribly surprising. However, there were a couple in there which I think really helped us to challenge some of the assumptions about how involvement might proceed, and in particular things like respecting humanity. So I think for a long time in safety investigations, there's been a sort of what I would see as a misunderstanding that an investigation is out there to get an objective truth, that actually it's not about relationships, it's not about human emotion, it is about looking at case notes, understanding some physiology, and actually we can come up with some version of an objective truth. And actually what we found from all of our work was that you know, there are emotions and there are people at the core of these processes, and we really need to respect everybody's humanity as a result of their involvement in investigations. And the other really important one was accepting subjectivity, and it's linked, I think, to that aspect that I've just talked about, which is that different individuals can experience the same incident in very different ways. And actually, this is really, I think, at the core of some of the concerns that people across the board have about incident investigations, is whose truth should be prioritised, who should we be listening to, and actually bringing all of those different understandings of the same incident together is an incredibly difficult job. And so I think from coming up with these principles, it really set us a good foundation to think about how do we create things which are going to be true to these principles, but not I think, pretend that it's a particularly easy thing to do, and to give people the confidence to say this is hard, but we should proceed anyway. And certainly that's something that I'll be coming back to later in my presentation. So what do we then do with these principles? Well, we brought together a really large co-design community. So it was a community of over 50 people that we worked with for over 6 months. And these were a community of people from policymakers, patients and families who'd experienced an incident, of course, patient advocacy organisations, we had healthcare staff in there, we had researchers, we had managers. So it's a broad, very broad group of people, and we were doing this in the pandemic. And so we had to think on our feet about how to share evidence with them, how to get them engaged in this, and that's probably a whole other presentation, and I'll be happy to take some questions about that later. But what we wanted to do was really say, whatever we produce has to be embedded within the reality of how people do this work and how people experience this work. And so it had to really be done with people, not for people. So that was our kind of guiding light, if you like. And from that, we developed 2 draft investigation guides, and we also developed a training module that went alongside it, a short training program for investigators to help them work with this guidance and help them support patients and families using this guidance. So these guidance booklets were designed to work symbiotically. So the same information, much of the same information was across those 2 things, but just written for the 2 different audiences, which was the investigators and the families and the patients. And then we tested these approaches, and we tested them across 5 different healthcare organisations, 2 mental health trusts within the Yorkshire region, 2 acute trusts within the Yorkshire region, and also nationally with the Healthcare Safety Investigation Branch within their maternity investigation programmes. And we did this across 14 months. We were lucky enough to follow 29 live investigations, and by follow, what we meant was when something was decided to be a serious incident, that then got flagged, was flagged to us, and we worked with the investigators who had been trained in the knee approaches to interview them, interview the families, interview any staff that were involved in that over a period of time, as long as the investigation was live, to really understand their experience of that investigation and whether and how they were engaging with the guidance, how the approach was working for them, the challenges of involving and engaging people through that process. So we got a really, really rich data set across those 29 investigations of both the challenges of doing this, but also how to support people to do it more effectively. So what did we learn? Well, we learnt a lot, it's fair to say. And I think the first thing that we learnt, as I've alluded to, is that rather than being objective, truth-seeking exercises, investigations are really complex. They are relational exercises that happen between people, and that the people who are undertaking investigations are trying to work with others to collectively make sense of all the different type of the available information that they have for them, but really doing that whilst working within the very complicated organisational systems. And this is something that I want to come back to later in the presentation, that actually whatever we do to support individuals within organisations to do the right thing and to try to and hopefully successfully engage and involve patients and families in incident investigations, that dyad, if you like, that partnership of involvement and engagement is only as successful as the organisational systems allow it to be. So I'll come back to that later, because the guidance that we produced was very much about supporting individuals to do this differently. But actually, when we tested it, what we saw was differences across the organisation about how different organisational infrastructures and systems supported those people trying to do the right thing, how they supported them or challenged them. So that's something that I'll come on to later. But one of the most important things that we learnt was that there is more than one reason to do an incident investigation, and more than one reason to involve families within incident investigations. And of course, as I've already said, the first reason is for learning. There's now very well established evidence that that actually patients and families can tell us about things that have happened, and that they can be a real source of very important information that allows organisations to learn about what happened when something has gone wrong within a healthcare setting. So learning is absolutely a priority. But there is a really important second reason to do it, and this was not something that I think certainly I, as a researcher, as a safety scientist, if you like, had really sort of thought about too deeply ahead of this programme. You know, we've gone into this saying, you know, patients and families are a missing piece of the jigsaw. We really, really need to involve them if we're to get a full picture of what's happened. And so as we worked with people, and as we heard all the stories from patients and families and healthcare staff, it's fair to say, we really, really started to understand that people have a range of needs that arise when something happens. And some of those needs are very obvious, you know, particularly in maternity, for example, or indeed anywhere. There may be, people may have experienced life-limiting or life-changing physical harms, and they may need to be repaired from that and have ongoing financial needs met for things like physio or rehab or ongoing surgeries and things like that. So it's absolutely our duty as an organisation, as a healthcare system, to meet those needs. Excuse me. But there may be a range of other needs. You know, there will be psychological needs that people have, you know, when something has happened. And we also learned that being involved in the incident investigation itself can either be a healing experience for families, or it can go on to actually create further harm for those families. So if organisations and healthcare systems are only interested in learning, what we've come to understand is that if they're only interested in learning and not in healing, we can actually cause further harm. And we've begun to understand this as something called compounded harm. So what do we mean by compounded harm? Well, this definition is taken from an article that I wrote with some international colleagues actually a couple of years back. And we define compounded harm as the harm that can be created after a safety incident due to the processes that follow. So those processes may be the identification of that incident. There may be, you know, there may be differences of opinion between patients, families, and organisations about what constitutes a harm that needs to be investigated. It may be the investigation itself. It may be coronial processes that sit alongside it, or even litigation processes that families feel that they have to go into because they're not getting the answers that they hoped for, or indeed the organisation is not even seeing their harm as worthy of investigation or right to an investigation or having met a certain threshold. And so what I wanted to do was to illustrate what we mean by compounded harm from a couple of quotes that we got from our interviews, in fact. And the first one is this: I wrote a really carefully worded complaint letter. I put a lot of thought into it. I tried to make sure that the letter wasn't aggressive or pointing the finger. But when I got the response, I've often said that was the worst day of my life. And a second example here. At one stage, I was so upset by the whole thing, I felt like taking legal action. But I was very aware that the NHS is a very large organisation and, you know, it was little me against them. I felt like I was in the boxing ring with my hands tied behind my back, and I felt desperate. So these were just two examples from our our data, and unfortunately there were many more examples. Compounded harm is a very real and very important issue, and it can really lead to lifelong feelings of anger, guilt, you know, particularly where for families which may have felt that they should have intervened or should have made their concerns known louder to organisations and to healthcare staff. So it is absolutely something which I think we should be taking seriously within healthcare organisations. And it's really my view that our duty of care as healthcare organisations does not just extend to physically repairing people, but also what we need to do is when harm occurs within healthcare settings, we should try, where possible, to work with them to meet their needs, to reduce this significant, sometimes lifelong experience of further additional harm. So the question is, how might we change how we work with families within investigations? How might we try to reduce compounded harm? And I think that the approach that we've tried to take, as evidenced by the common principles that we developed that are foundational to our approach, is that actually we genuinely need to listen to people. We need to sort of listen to families, not just about what they tell us about that we might benefit from in terms of organisational learning, but their wider experience of how incidents have affected them, what their needs are, and try to work with them in ways that can help meet their needs. So the big question is, can it be done? Well, we think it can be done. Certainly we think that there are ways to try to reduce compounded harm. And we have developed and tested, as I've already said, our approaches across different organisational types. And we've designed these processes to work within the systems that, you know, within the constraints, within the challenges, within the types of processes that people use currently within healthcare systems. So this is the Learn Together website. It was officially launched to coincide with World Patient Safety Day. You can go on there, there's a QR code, and hopefully the slides will be made available afterwards, or you can just Google. I can see in the chat that there is that Kelly's very helpfully put up the website there. You can go onto the website, you can download the materials, they're free to download. You are, as healthcare organisations, free to adapt these guides for use locally. And also on the website, there are a number of different resources, including some videos, one of which I'll show you in a moment, whereby we have tried to really help people who are experiencing investigations for the first time to understand what might happen as a result of going through the investigation, and to normalise some of their confusion and their feelings that they might be experiencing as they go through an investigation. So we've got, at the moment, and we're working up some more, we've got 3 videos that you can go on, and also an animation that explains the different stages of the Learn Together process. So do go on there, have a look. I'll be really interested in any comments and thoughts, because we are hoping to revise these over time. So at the heart of what we call the Learn Together approach is this. It's the 5-stage process, and it's really a flexible approach that supports people who are investigating incidents to be family-centred in the way that they work with patients and families, and to really humanise what can be a very confusing and potentially quite re-traumatising experience for families as they go through the investigation. So this isn't an investigation tool, it's much more an approach to support, alongside whatever investigation methods that are being used, to support the engagement and involvement of families. And we've split it down into 5 main stages. So in keeping with the learning and listening, we have the first 2 stages, which are about listening. And the first stage is really, and this is something which came about from our co-design phase, probably more than anything else. And we, in the initial versions that we piloted, we'd much more focused on giving information about knowledge. So the people that we'd worked with had said, you know, I needed to understand, I needed to be able to navigate through this process. And so we sort of jumped into, here's an investigation, here's all the jargon, here's, you know, jargon busting information that can help support you through the investigation. And then what we experienced in the testing phase was that by jumping in and sort of just introducing this approach about what organisations can get from patients and families in terms of their involvement in the learning, what we realised is that we really weren't dignifying the experience of being involved in an incident. So in the final versions, these revised versions, what we've really tried to do is to centre listening and supporting as the first part of this process. So stages 1 and 2, about sitting with patients and families and just hearing from them in their own words what's happened, without sort of going into the nuts and bolts of this is what an investigation is, this is how you can get involved. It's about dignifying their experience in ways that allow them to talk about a loved one if they've lost their loved one, or if they're speaking for a loved one, or themselves. So it's about sitting with families. It's about then in stage 2, agreeing how you might work together. And for some families and patients, it might stop there. They might say, look, I've said what I want to say, you know, I'm very happy for you to go away and do what you need to do and just give me the final report. But for others, they may want to be more involved in actually giving and getting information, providing information that can help organisations learn. So stages 3 through to 5 are much more about supporting the organisational learning aspects. Stage 3, as I say, is about that process where within an investigation, you will be going out as an investigator and trying to source different types of information. That might be clinical notes, it might be speaking to healthcare staff, it might be looking at the roster, it might be doing any number of things. But actually within that, if the families have suggested that they do want to be involved, it's also about involving them to give their version of events and support that making sense, that putting the jigsaw together of what's happened. Stage 4 is a really important and new part of the work that we're doing, and I'm going to go on to talk a little bit more about this as part of the challenges section at the end. But what we introduced as part of this process, and that came very much from patients and families who said that this was a really, really integral part of the process, was about checking and finalising the report. So being partners in producing the final report, not just that patients and families receive the final report as a fait accompli. So it's about saying, can we introduce a further point, a further check in the system where actually we're, as organisations, giving a version of the report which is not yet completely final, and give families an opportunity to look at that report, to check what's in the report in terms of their contribution to that, but also even potentially make comment on some of the other things that within the report. That's up for debate at the moment. But it's really about saying the report is not finalised until the family have been given the opportunity to check it. So it's about having them as a sort of final, a partner in that finalising of the report. And then once the final report has been agreed by all parties, then it's about saying there are some next steps that as an investigator you can't necessarily, and you're unlikely to be able to support people with all of their needs that might arise at this stage. But actually as an organisation, you might want to direct people to different other supports, or that might be within the organisation, but also might be out with the organisation and part of third sector organisations, for example. So it's very much about saying that the investigation closes, but that you as an organisation, you as an investigator, know that it might not be the end for the family, and recognising and dignifying that closure of the investigation. So what I'd like to do now, if it's okay, is just to play you a video that is on our website that really explains a little bit more about the process. And as I didn't, did I share? Maybe I did. Lorraine, will you let me know if you can't hear this? So I'll go ahead.
Yeah, we can hear it.
My name's Deb Hazeldine, and I became a patient safety campaigner without even knowing it in 2006 when my mum died horrifically in a mid-staffs disaster. She was admitted for physiotherapy and she died of C. diff. Over many months of trying to complete physio, she would tell me that she was in pain in her back and in her ribs, and when I raised these concerns, my mum was told that the pain was all in her head and that she just needed to go through the pain barrier and become mobile. And it wasn't until after her death when I read in the notes that she had preventable falls in hospital and she had fractures in her back and in her spine. Absolute despair. I just couldn't believe what was happening in front of me, what was evolving in front of me, and I felt so unable to do anything. I raised concerns and nothing changed. But no, there wasn't an investigation. It was just, oh, your mum was going to die. Didn't for a second think that when my mum had died, that when we raised valid concerns that nothing would be done. We thought instantly somebody will do something. And my daughter was 12 when my mum died. She was 19 and at university when we sat in London listening to the outcome of a public inquiry which stated some systemic failings at that point. And I never thought it would take that many years. The only time I was able to give my mum a voice was many years later with the lead investigator to the Healthcare Commission. He sat down and said, Deborah, tell me what happened to your mum. That was many years later. I needed someone to say, I'm sorry that this has happened and acknowledge that my mum had been failed. When my mum died, when I searched and looked, for quite some time there wasn't anything that I thought was supporting the families. There wasn't anywhere that the families had a voice. And it always seemed as though it was the system doing something to you. So it was a system or an investigation that you weren't part of, and I couldn't quite understand how your most dearest loved one wasn't having a voice if you weren't there actually sitting at the table. I was contacted by one of the lead professors, Jane O'Hara, to see if I would be interested in being involved and getting a brief summary of what they were trying to achieve. I thought that's exactly what I would have wanted when my mum had died, so yes, I wanted to try and help if I could. All the way through any of the investigations, the booklets, the documentation, families were asked their opinions, and it was incredibly emotional to go through, to think with my own mum's death, nobody had asked my opinion all the way through for many, many years. To then see an investigation that could change things felt very emotional. I would have used them for me as a tool to be able to highlight what was missing and to be able to hold people to account, to say you've not done A, B, C and D, there might be a reason, but why haven't you? And if this has been highlighted, what do I do now? Where do I go now to get this information? It would have given me much more knowledge, whereas you go in blind, you don't have any answers, there's lots of jargon, families don't know what to ask and don't know how they can ask that. If I'd have had the booklet to say this is the way that it should go, I'd wanted to be able to hold people to account as to if it did and if it raised other issues and if it asked other questions and it highlighted those, I would then want to know who deals with that. Information for me, knowledge is power. And if you don't share that, we can't ask questions about processes that we don't understand, that we don't know, that we're not involved in. And families desperately, I've found over many years, they want a voice. They want to be able to say, this was my loved one, this is our family member, can we please be involved? And having everybody feeling that they are supported and that they matter, because we all matter to someone. Honesty, transparency and candour would have changed my life dramatically to this day. I think the investigation gives you the voice, it gives you the ability to be involved, but I don't think it can give you all of the emotional support that you may need. And I think that's why with the reports and the booklets, there is other signposting to other organisations that might be able to do that for you, because you may not know, I didn't know on day one what I needed. First and foremost, be kind to yourself. with the process that you're actually going through. It's the most emotional time to go through. And don't ever apologise for being emotional. If you're at a meeting or if you don't understand something, ask and ask again. It's really important that you understand what is happening. And don't be afraid to ask for support. You might not be able to be involved, but you might have another friend or a family member that can support you. And don't be afraid to say what you need. And I spent so many years standing in the wind and the rain and the snow with a candle and a picture of my mum, thinking that these conversations would never begin. So to know they're still continuing all these years on, that's what gives me hope. People are now speaking about patient safety, investigations, whereas nobody wanted to speak about it when my mum died. And the one thing my mum would want me to do is to never lose hope. You either have hope or despair. I haven't got the energy for both, so I held on to hope. I know she stood next to me every single time I stood there with a photograph and a candle, and I couldn't have done it without her.
So I always get a bit emotional when I hear that from Deb, because she's been such an amazing part of our work. She was the original person I spoke to when I put in the grant application, and she's been with me all the way through. So just a very public thank you to her for all her support. And I hope that playing that has brought a little bit of the Learn Together approach alive for you and made that a little bit more real. So very briefly then, just to say that the approach that we're advocating and the evidence that we've developed, we've been lucky enough to work with in collaboration with the Healthcare Safety Investigation Branch. So that's the National Independent Investigatory body for NHS England, and also NHS England as part of developing new guidance on engaging and involving families following a patient safety incident. So our evidence and our approach has gone into the current guidance. It was released last August, and in a, I think, unprecedented policy synergy, they've committed to following, because now we've got all the evidence following our testing phase, they've committed to actually integrate the new versions and the new evidence that we've generated following the testing phase into this guidance. So it is very much a work in progress. As evidence is being generated, that's going into the new guidance. So it's just been an amazing opportunity to really impact policy, but hopefully practice through doing so. And myself and colleagues who worked on the policy together, we did a podcast. It was a little bit cringy, but if you are interested a little bit more about how we did that collaboration and what we did, that you can go on and listen to that. So to close, no, I didn't want to come along here and say, oh, everyone adopt the Learn Together guidance and everything's going to be absolutely brilliant following that. I think it's fair to say that one of the things that we did learn in our testing phase is that reducing compounded harm sounds like it should be straightforward, in a sense that you do these things and then everyone will get what they need. And I think that is a deceptively simple version of events. It is evidently morally the right thing to do. I think what we try to do with the Learn Together approach is to really break it down and provide support for people to do it better. But it's fair to say that it is not without its challenges. And I'm sure many of you will be sitting there thinking, oh my God, this looks great, but, and so I wanted to really speak and be honest about some of those things. So what we've really discovered, I think, is that the path to compounded harm may not actually be because people are not well-intentioned. That everybody might be signed up to this way of working. So investigators, middle managers, senior people in organisations, they all may say that this is the right thing to do. So why is it difficult? And we started to think about, It's difficult because there are divergences, there are differences in what people want and need across different parts of organisations, and certainly between patients and families and healthcare organisations. And so I've tried to present a couple of issues here that really illustrate that. So within the new patient safety incident response policy, for example, within NHS England, that new guidance says that actually incidents should be prioritised for investigation if they have the greatest learning potential. But you can immediately see from, you know, the evidence that I've discussed today, and indeed I'm sure many of you will have other experiences that will resonate with this. When something happens to you, you want answers about your experience, and that's absolutely right, isn't it? You're not going to necessarily say, oh, well, it doesn't have an incredible learning potential for the organisation, so I understand that you don't want to investigate. You're going to say, but what? This was my granddad. What happened? I need to know in order to help support my healing and my learning about what happened, and to you know, close the circle for me. So there's a real inherent tension sometimes between, I think, what we want to set up as a system safety approach with what people actually need. And then one of the other really important things is the difficulty of people who are trying to do this better, who are trying to create environments where they can be family-centred within investigations. Sometimes the organisational systems that they sit within just really don't accommodate that. They're just too rigid, they're too brittle, and they can't be moved to create these family-centred approaches. And an example of that is for things like limiting the terms of reference. Oh, no, that's out of scope. We can't answer that question for you. And particularly in the context of what I'm going to talk about in a moment, the draft report and finalising the draft report, there's a real nervousness about opening that up and making that more transparent. And from a patient and family point of view, they might want flexibility. They might need more time than organisations are willing to give to review a draft report or to provide their information, or they might need you to come to their home in order to feel safe and in a psychologically safe space to share their information and to feel heard and validated. And so the ability of people within the system to deliver it in that way can have real significant abilities on the success, really significant influence on the success of their approaches. So to close, I just want to give you an example, and this is from, as I say, stage 4, checking and finalising the report. So when we first introduced it, we probably knew that it was going to be a point of contention. So it came in, as I said, from the co-design process. Families were absolutely adamant that if organisations that to sign up to transparency, that they really should be enacting this via the medium of allowing families to comment on, to shape, where possible, the final report. And so we knew that it was a critical point of the success. Interestingly, at the same time as when we developed this through the co-design process, the policy changed. As I say, the policy changed, the new incident response framework came in NHS within England, and it actually mandated that sharing of the draft report should be part of good practice within investigation management. So we knew that there was both a sort of moral driver and then a pull from this new policy change. We knew it was going to be a critical point of success. And when we spoke to investigators, they welcomed it in principle, but they were very nervous about the practice. And there was a concern, I think, that for us as designers, co-designers of this new way of working, that does it sort of, do these problems put the organisational processes above the needs of patients and families? Because if investigations are to learn, it's right, isn't it, that patients and families should be able to see the draft report if they're going to amend any inaccuracies or to make suggested changes. But what we witnessed quite quickly, aside from the obvious nervousness, and that we think, you know, that largely comes from think, you know, concerns around reputational risk and opening yourself up as an investigator to criticism from the families. It's a very human response to be nervous about that. But there are other systemic problems as well. So there were timing problems within organisational processes. So organisations didn't know exactly when this might happen. So is it after the accuracy check from clinicians? Is it before the governance sign off or after the governance sign off? How draft is the draft report? It became a really important discussion point within organisations. And there was, as I say, the influence of these competing pressures. So reputational damage wasn't talked about explicitly, but it was always there in the background. And so there was a sense that the nervousness was coming from a need to keep control of negative information. So what we've learned is that really, beyond anything else, this point of the process is the put your money where your mouth is moment. You know, it gives organisations the opportunity to say, we are committed to transparency. We will change our organisational processes to try and accommodate you to have time to comment on the draft report. But also, really importantly, it addresses some of the other needs that we're not really very good at within organisations. It allows us to dignify the person that has been harmed or the loved one that has been lost or harmed. It supports people making sure that the details are accurate. Is their name right? Is it their preferred name? No, you were wrong that you said that they were a smoker. They weren't a smoker. And for some people, these small details are incredibly important because it gives a sense that the organisation, if they're really able to deal with these small details about their loved one or about themselves, that actually they're attending to everything with dignity and with care. So it supports that belief in the transparency and that you are committed as an organisation to working together. And a really important point before I close is that actually we think this may be a really pivotal point, that if you are able as an organisation to actually open up the possibility of feedback on the report and then act on the feedback that you get, that there's a suggestion that actually how you act at that time really is the important point for deciding whether patients and families might want to go on to further litigation or other complaints processes, because it really is a point where as an organisation you are enacting those principles that we outlined earlier of transparency, of dignifying the human experience. So it needs to be demonstrably a point where things still can be changed, and that, really importantly, that they are changed as a result of that feedback. So to close then, I do want to say that, you know, the Learn Together approach, I would say this, wouldn't I, that, you know, it has a real possibility of providing a structured, systematic way to put patients and families' needs at the heart of investigations. But it does come with a bit of a warning for organisations to say that even if everybody says that they want something, getting it embedded and being true to the process is really difficult. So we've, you know, a lot of work often in these things is about the relationship between investigators and the family, but what we need to know much more about is the process of working, how these processes work within organisations and with policy, and how regulators can support these things, because we know that people will do in organisations what they're performance managed on and what they are regulated and accountable for. So actually there is a bigger conversation to be had with in organisations, but also with policymakers and with regulators about, if people are to do this, they need to be supported to do it differently. So that's my sort of final point, really, that actually we do need to listen before we learn, if we're not to reduce compounded harm, but actually we need to take a really good look at the foundations on which this approach works, because if those foundations aren't solid, it might be really difficult for investigators and it might not work for patients and families. So I think, as I say, that's my sort of final point is that actually you do need to look within organisations at how these things will work. It's not good enough just to say, oh, we've got some booklets, give them out to some investigators and it's going to work. As you guys will be thinking about now with open disclosure, the infrastructure around disclosure is as important than any sort of systematic attempts to do that disclosure. So it just remains for me to say thank you to all those involved in this programme, and I will leave it there.
Thank you very much, Jane, for a very empowering, I think, and presentation around the importance of patient engagement, and I suppose it kind of replicates this ethos of our work here in Ireland in relation to, you know, increasing openness and transparency and being more inclusive of the patient involvement in the open disclosure and the patient or incident management process. We're just going to move into a panel discussion now, maybe, and just take some questions from our attendees today as well. So first of all, just maybe to welcome our panel here today. Just to introduce people who are here, so including myself and Lorraine and yourself, Jen, who people have met already. We have Bernie O'Reilly, who's a patient representative, and Bernie has her own personal story, and she's also a member of Patients for Patient Safety Ireland. We also have Georgina Cruz, who's a national manager for the Patient Advocacy Service. We have Loretta Jenkins, who's a general manager in the incident management team. And we have Kelly McDyer in our office and Sandra Lehman, who are both from the National Open Disclosure Office as well. So just thanks to all our panel today. And I feel, Bernie, I must go over to you first of all, because I suppose having heard Jane's presentation and Deborah's story, I'm sure that a lot of that resonated with your own personal story, Bernie, when you lost your husband, Tony. And maybe just to go over to yourself, Bernie, in relation to your perspective on all of this.
Well, thank you, Jane. That was absolutely fantastic. And Debbie's story nearly started me crying. So, I mean, it's the same year as my husband's death, and that's what my family story is based around. But absolutely, I mean, you have to keep communication with families. You have to keep them. You have to move with them. You have to journey with them, and equally, you have to journey with your healthcare workers that are involved in incidents. Like you just have to keep people talking, because like you lose people. People get driven in directions. If you feel that your questions are not being answered, you're probably going to go one of two ways. You're either going to go into the media with the story, or you're going to go to a solicitor. And once you start into those processes, it's very hard to come out of them. You're actually trapped in them. And I just think it's. I also love where you mentioned that you have to learn, and also. I forget exactly what the term was, but that you have to do more than learn. You know, you have to actually have that compassionate response and be willing to make change. And I think you do have to, like, some people won't want to be involved in, you know, in a high level in the incident management, but for the people who do, like, it's disrespectful to keep them out of that process. You know, if they have something to contribute. And like, I mean, I've been in this area for 17 years. Like, what keeps me here? You know, I'm a volunteer. I don't get paid for my work. So what keeps me here is the hope that change will come. And that change is slow, but like, you'd like to think that things are better now than they were 17 years ago. But like, it's taken people of determination and goodwill to move that agenda along. Mm-hmm. And that's what we have to just keep chipping away at it and working in a positive way to make that happen.
Thank you very much, Bernie. And I suppose, as knowing your story so well, Bernie, having worked with you for so many years now, I've just gone about the whole thing around the healing process for you, and how you've spoken to me before about how healing it was for you to actually get answers to your questions. I know you didn't get all the answers even at this stage, but that was very important for you and your daughter at the time, wasn't it?
Yeah, well, it is important, because like you can't repair death. How can you repair death? Like, you cannot repair death. The best you can hope for is change. Because at the time of my husband's death, I feared for every person undergoing surgery, because my husband died of sepsis, which technically is a risk that everybody signs off for. You know, you can get sepsis, post-surgical sepsis, and it's a risk you sign off on. But his care path that day, in my opinion, wasn't good. So I became fearful for myself and other people facing into surgery, because if it happened to my husband, it could happen to you, me, or anybody else. And at the time, I just felt nobody was listening to my opinion on the safe systems and what happened the day of his surgery. Was it a one-off event? I didn't know. I'm not a medical person. I don't know what happens in operating theatres. So I mean, Tony's death was dismissed as being sepsis, hospital-acquired sepsis. But the whole process of his care that day was called into question, and nobody ever gave me a hearing. I was, what did I know? I didn't know the processes. Maybe the processes of Tony's care that day were the processes that lots of people experience. I'd hate to think I would experience being left in an operating theatre for 2 hours while the surgeon went to do with somebody else. Like I just was horrified, and I still am. 17 years later, I still am. You'd hope that there are safer systems around surgeries now, that there are proper rotas for surgeons to protect the surgeon themselves as well. Like, who wants to be in that situation? Who wants to be compromised in their care of a patient by a challenging system? So sometimes the systems do need addressing, and if it's by a patient, what better person to address a safety issue on behalf of everybody than a patient who's been harmed, or a family of a patient who's been harmed? So I totally enjoyed listening to you, Jane. I think your work is fantastic, and I hope that the HSE, in developing their own work, who've already done brilliant work, but I hope that that they pick the best of what you have and bring it forward to enhance their own work. And the HSE have done stellar work, but there's always more to be learned, always more to achieve, and we just have to keep on developing and growing and traveling with people and taking on new systems which are safer systems.
Thank you very much, Bernie, and we so appreciate you, Bernie, and how you've contributed and helped us on that patient safety journey over the last number of years, and particularly in the area of open disclosure and incident management as well. So thank you for that. And just, Georgina, just go over to yourself. We're all working together, HSE, with our patient partners, with our patient advocacy partners, and we're all trying to improve that patient experience. Just can you tell us the learning from your perspective, what your experience has been from the patient advocacy service perspective?
Hi, thanks Angela for that, and thanks Jane for your presentation. I suppose in our work we've seen both sides. We've seen when a patient isn't facilitated in the open disclosure or the IMF review process. We've had cases where we've worked with people that haven't been involved in the open disclosure. They haven't been told that a review has been carried out. They may have discovered that when they FOI'd their files, so there's been no involvement there. In some cases, they've seen the review at the end stage when maybe the final report is available, so they have had no opportunity to have any input into, correcting those factual inaccuracies. We've had cases where they haven't had the opportunity to meet review teams at the start or the end of the processes, or have sight of the draft reports. So I suppose their voice and experience goes unheard. This can have a hugely negative impact on the person themselves, and it can lead to like a complete breakdown maybe in the trust and relationship with the service. And I suppose it leads to that compounded harm. There is that re-traumatizing. And in cases, as Bernie has said, it can escalate a situation to litigation where it might not have been necessary. So we have found when advocacy support has been in place that it is more of a positive experience for the people involved. Often, I suppose, with our guidance, they know what to ask for. So around open disclosure, receiving that sincere apology, and having input and sight of maybe terms of reference, that they're not too narrow. They're given names of the review team. They get that opportunity to meet the review team at the start of the process so they can give an account of what happened to them and the impact that it's had on their lives. you know, I suppose it provides an opportunity as well for the patient to ask questions about the review process, and also maybe to raise questions that they'd like looked at and carried out during the review. I suppose empowerment advocacy allows the person to feel that support and that their voice is elevated within the process and their lived experience is taken on board. It also allows, I suppose, for us to manage expectation, because the IMF does look at processes rather than apportioning blame, so it can be quite a complex thing. And our service uses the feedback from them themselves is that the advocacy support during that process is invaluable, because it does explain to them the steps in those layman terms. It guides them through each step, as Jane was saying, the understanding of the processes there ensures that they have some sort of sounding board, I suppose, through the process. You know, if they don't understand it, or even if staff can't explain it properly, you know, they have an independent support there, you know. So we have found when people are involved and included in the process, it does provide that opportunity for them to elevate their voice and, I suppose, highlight their lived experience. And it normally leads to that more compassionate, respectful kind of communication between the services and the person, and it kind of promotes a bit of partnership in learning as well through the whole thing.
Thank you very much, Georgina. And just a question for yourself, Jane, just from the chat there. We're currently exploring the concept of learning systems and the different constituent data elements of what that is, and also how that data gets used for improvement. Can I ask how your fabulous work fits in with the complex learning jigsaw, and how the reports generated actually result in changes and improvement?
Well, it's a really good question, and this is the bit that we're all trying to get to, I think, in the world of safety, is moving from data to action. So I think, you know, obviously this work has been focused on centering families and getting their voices heard, first and foremost, improving the experience, trying to improve the learning, trying to kick off a bigger, what's become a global discussion about what the role of investigations has been, which is just brilliant to watch. But you're absolutely right, you know, learning what, well, I always come back to, I don't really know what learning is. Is learning a thing that is some stuff over here, or is it a process that organizations go through to reorder how they understand, you know, a particular process or a particular treatment pathway or whatever it is? So I think all of these things are really good points. What I would say, I would certainly say that none of us have the answers at the moment. What I would say is that within the English NHS, we are the new policy is really trying to support or to promote the idea that healthcare organisations need to look at a variety of different types of data, not just past harm, and they are explicitly making the link between safety investigations and complaints and the improvement processes. So for the first time in policy ever, there's been this sort of like, actually, why is improvement over here and safety management is over here? It's actually that those two things should be speaking to each other. So the hope is with that, excuse me, with that policy, that actually going forward, there will be a much better link between knowing what's happened and some of the reasons why those things have happened, and then linking into improvement work going forward in trusts. And as Ray mentioned, I am leading the evaluation of that, the implementation of that policy within the NHS in England. So that's certainly one of the things that we're going to be looking at over time, is how do organisations, excuse me, integrate different types of data and learn from those different sources of data. And Graham Martin and Mary Dixon Woods talk about that really nicely as soft intelligence. So it's about how do we incorporate these softer, more story-based type information into our safety management systems, I think is an ongoing inquiry. So it's a brilliant question. I'm not sure I have the answer, but hopefully over the next few years, we will have some more data on certainly how policy might support that way of working.
Thanks very much. Jane, you probably answered there, but the second part of that question was, is any data being collected around completed reviews that have shared the draft report with families?
So as part of our testing phase, we were testing that process out. So that's why we've kind of got the learning that we have about some of the challenges. I think it's fair to say within England that there's 4 pillars in the new incident response framework. There's 4 sort of key areas that are changing the way the organisations are supposed to respond to incidents and learn from what's happened. And compassionate engagement is one of those 4 things. And whenever I talk to patient safety managers and people from organisations about the move to this new framework, the engagement is the bit that the organisations are most concerned about. And I think it's for lots of reasons, including this big shift to we decide what should be investigated, we decide how we're going to investigate that, we decide how we're going to involve you, and we decide what gets acted on. And if we are going to share the draft report with you or not. So it's a real sort of test of that positioning of organisations being the source of what is investigated, how it's investigated, all of that stuff, to actually thinking more broadly about, okay, there are people within this process. So I think going forward, as I say, we're evaluating the implementation of this new framework, and the new framework does mandate the sharing of draft reports where possible. So that's going to be one of the key things that we're looking at. The implementation, many organisations still haven't moved to this new way of working. A few have. So that's one of the things in the evaluation of that we'll be looking at. So it's a really lovely tie-in from the work that we've done in Learn Together with the new policy, because we're able to see at scale, is this actually happening in organisations? So it's a work in progress. We will come back with data on that one, hopefully, to answer that question in the future.
Thanks very much, Jane. And probably Lorraine, it's time me to go over to you at this point. I know you're very passionate around this whole subject of more inclusion of patients and their families in this whole incident management review process. Why do you feel it's so important, and where do you see the difficulties around that, Lorraine, in Ireland?
Yeah, I suppose for me, it was an excellent presentation, Jane, and thank you, Bernie, and Georgina as well. I mean, you echo all the sentiments, and I think everybody on this call today shares the same passion and interest in it, and we want to get to that place, don't we? So for me, I suppose incident management is always referred to as, you know, the purpose of incident management is for improvement and learning and so forth. But one of the key pieces for me is about that relationship piece. You know, how do we interact with those people who have been impacted by an incident? How can we bring them on that journey? And how can we come out the other side? And obviously, and sadly, we've learned of poor experiences around that, where there then is a lack of trust and difficulties in terms of people engaging with the healthcare service, and even some feedback about staff or patients not wanting to raise concerns because they continue in the care of the healthcare service. So it's really to have them in as partners and to support them through the incident review process and to regain their trust if there's any challenges or any breakdown in that, so that they can, I suppose, heal and move forward. So yeah, I think it's having a lens on that. So it's about improvement and learning, yes, but it's very much about the relationship piece, you know. People will have been harmed. So I suppose the difficulties that I see within the again, Jane, you listed quite a few of them there, and incident management, it's very process driven. We've always had that mental map, and it's always been helpful for colleagues and everyone to kind of take you through a step-by-step process. But I think that human piece is maybe being a bit lost in that process. And you touched on one of the points there in terms of reference, you know, we're outside of the scope with this piece and that piece. I think if we bring patients or their relatives along with us from the outset, incorporate their needs and address them as well, then and they are involved, and there shouldn't be any surprises in terms of the findings when they get the draft report before it goes to the commissioner, and that because they would have been part of that journey, I suppose. And as everyone has noted, like their insight is invaluable. You know, we sometimes get criticised in incident management that we maybe aren't learning as much as we could or should, and if we don't listen to the patients and their partners and don't get their perspective, then it's difficult to make improvements. So, yeah, thank you.
Thanks very much, Lorraine. And just over to yourself, Loretta, what advice would you give to QPS colleagues in consideration of this whole area of patient involvement?
Well, first of all, I want to thank you, Jane, for a really insightful presentation, and Bernie again for sharing your story, and Georgina for keeping us up to date, you know, in terms of, you know, how the service user and their families feel during the review process, and the outcome of your really, really good national annual report last year. In terms of greater patient involvement, I think it's really, really important that at the initial briefing, that we explain the purpose of the review and what that roadmap is going to look like. I think it's important that we practice active listening and listen to the story of the patient. And as Lorraine said around the terms of reference, you know, the terms of reference under the IMF, that we aim to involve the service user and incorporate their questions in the terms of reference. And I think it's really important, as we've said before, that open communication, that continual communication between the service user and the organisation, to the point where that, you know, with the reviews that we've been involved in the past, it's important to agree at the outset how often the service user and their families want to be updated. And sometimes that could be once a month, it could be when you have new information, but it's important when you agree that you keep to it. You know, you may not have new information, but you keep that line and that door of communication open all the time. And of course, then if there's any supports that the service user needs, that, you know, that is accessed. And I know that you have, Kelly might put up the link to the list of supports that are available through the HSE.
Thanks very much, Loretta. Yeah, and we have two very good documents that outline the supports that are available for staff and also the supports that are available for patients and service users. So the links are to both those documents in the chat today. Just another question, Jane, just coming from the chat there. When considering patient safety, who should be responsible in determining the level of risk, and who should take lead in writing incident report when the incident has occurred when two learning systems, hold on again, sorry, I've lost it there, just moved again. Right, when an event has occurred when two organisations or services are indicative in the patient presentation. Sorry about that.
These are some great questions.
Yes.
you planting these questions, these are brilliant. So again, I don't have answers to these questions. I think these are debates that have been happening for quite a long time in the world of sort of patient involvement and engagement, because obviously patients and families don't experience healthcare in the way that we set it up. You know, they don't, and you'll go to your local general practice, you know, general practitioner and see them, and then they'll refer you on. It's not like, oh, look, I'm moving between employers now, and you know, they have their own risk management processes over here, and you know, it's just the health service, isn't it? So you sort of, it's an artificial set of structures that we create to deliver and commission healthcare that really isn't experienced like that for families. So when something happens, you know, it may have happened across different employers, and actually it may have happened because things are moving between different employers and different healthcare settings, and actually they wouldn't necessarily be picked up only within one of those settings. There's not necessarily responsibility between one of those settings, but actually something that's happened between those settings. And so in some of the work that we've written about, we're calling these sort of safety gaps that we set up in our services. And I think this is one of the areas that highlights just how problematic that is, because actually when something's happened and harm has been experienced, if it's been experienced as a result of people moving between and within services, who does take responsibility for that and moving that forward, I think is a really important point. And it's something that I think needs to be guided by policymakers in actual fact. And I know that there are certain innovations. So certainly over in England, we've set up these really complicated integrated care boards now, which are commissioning services across different settings to try and recognise the fact that actually families experience care in, across settings. How that will enable things like safety incident management, incident investigation, I'm not entirely sure. Again, these are all new things and things that we're looking out for. But I think certainly for me, if we're to be family centred, the future of safety investigation should be across settings, and trying to understand how incidents occur over time, over different healthcare presentations, is really, really important if we're to actually reduce harm properly. So again, I haven't answered, but a really, really great question.
Thank you. And just another question there. When the report is finalised, what is the process in the UK? Is there an opportunity offered to meet with the patient or family and a member of the clinical team or QPS team?
So I think it's really on a case-by-case basis, I think, and will be driven by, and again, I noticed in the chat somebody talking about the role of investigators, and I think this is a really, not just the role of investigators, but the being an investigator is really, it's not largely understood, I don't think, and that's probably for another presentation entirely, because there's a whole host of issues. But one of them that we've seen in our organisations that we work with is that actually a lot of this is driven by the preference of investigators, how they've worked before, what they bring to the organisation. So they will openly say, oh yeah, Steve does family meetings at the beginning and the end of mental health investigations where somebody has completed suicide, for example, but actually I don't do that. So there's a real lottery, I think, in terms both across and within organisations, depending on people's experience and how comfortable they are with different methods. So I think we would be advocating in our approach that you should start with meeting people, you should end with meeting people, and that, as Loretta said, and Bernie, the process of engaging people throughout, even when there isn't information to share, is so important, because it's about the relationship. That's where the trust is built. That's how you keep people engaged. And so if you start with the idea that meeting with people is a good idea and understanding them and their needs, then actually everything flows from that. So I think we're certainly advocating that. Does it happen at the moment? I think it doesn't happen as much as it should.
Thank you, Jane. And I see, Lorraine, you got your hand up there. Did you want to come in there?
No, I suppose you're saying you don't have all the answer, Jane. Was just nice to listen to you and the sentiments. And I suppose for us, it's, in the Irish context, like, how do we take this forward? Because obviously the resources are easily accessible in that. And when we spoke before, obviously there are a lot of developments in terms of open disclosure in the Irish setting, with the Patient Safety Act being enacted this year. And I think for us, it's very much not to lose the focus on that engagement and involvement of patients, and not get too drawn into some of the technical elements maybe that will be coming through the legislation and things like that. So I think the webinar has been really timely, and Angela and colleagues have been very much driving the role of the designated person. I don't know, Angela, you might want to speak to that as well, and how important they are in facilitating this.
Yeah, I suppose in our work in open disclosure, we'd see that the role of designated person just hugely significant in just what you're talking about here today, Jane, so that a contact person is assigned at a very early stage in that process when an incident has occurred, and the role of that person engaging with the patient and their family in finding out what their concerns are, what their questions are, and helping them prepare for meetings, be it meetings around the review or meetings, open disclosure meetings, and bringing information back to the healthcare team, so that when the healthcare team meets with that patient and their family, that that they're going to be able to address the questions and concerns that they have raised on the day. And that there is somebody there on the day to actually meet and greet that patient and their family, to bring them to the room, to settle them in, to introduce them. All of that, I think, is really, really very important. And we're doing a webinar next month, just dedicated totally to the role of the designated person in incident management, open disclosure. And also, we're going to be just liaising with some of our colleagues across the system who actually work in that role, and the learning that they've had from working in that role from patients as well. Lots of very positive comments in the chat there, Jane. I think you're going to be getting quite a few emails after today's presentation. So thank you very much again for that. And just we are at 1 o'clock now, so maybe we probably didn't get to all the questions, but we are at 1 o'clock, so I think we will finish up for today. So Jane, just thank you on behalf of the Instrument Open Disclosure team, just to thank you sincerely for joining us today, and hopefully we can get you back again, maybe for our webinar, maybe again next year, if you'd be willing to do that. And I think this topic will, I would love to see this developing more in Ireland myself. I know it's something that the whole team are keen on. So, and watch this space maybe. So just to finish off, just a reminder to everybody, you're probably tired of hearing me say this by now, but just to remind you all about the importance of completing your mandatory training in open disclosure. Module 1 is for all staff. Module 2 and Module 3, which is the face-to-face program, is for all staff who, as part of the role, have to engage in open disclosure as part of their role. So you can get those modules on HSE land. The face-to-face training you can access through the open disclosure lead for your area. I've already talked about the webinar next month on the designated person, and just to remind you that the designated person now is it is involved in the legislation, both the Patient Safety Act and the Civil Liability Amendment Act, so a really important role in relation to the implementation of the Patient Safety Act going forward as well. So come along and hear some of your colleagues talking about that next month. Just in relation to the next QPS talk time, that's going to be live from the NPSO conference next Thursday on the 19th. And myself and Lorraine are going to be speaking on the talk time for a short time around the open disclosure framework, which is going to be launched at that conference next month. So just a big focus on open disclosure at next week's conference, with the launch of the National Open Disclosure Framework, a presentation on that framework by the National Patient Safety Office, and then a panel discussion where you're going to, facilitated by Dr. Orla Healy, you're going to have members of Patients for Patient Safety Ireland. Georgina will be there. I think Bernie's going to be there as well from the patient perspective and the patient advocacy perspective. We'll have HICWA, and we'll have members from NIMBY on there as well, and also frontline clinician who's going to talk about the open disclosure, the next steps for us. So that should be an exciting day for us all. Just in relation to your attendance today, you will receive an email with a short survey on today's webinar. We do get assessed in relation to our compliance with the CPD process, so we do need you to complete that evaluation so we can send you your cert. If you do want your cert, just email the Open Disclosure Office at opendisclosure.office@hse.ie. And as always, if there's any other topics you would like us to present for you, just do let us know in your evaluation. We'll be delighted to hear from you. Again, a lot of the topics that we present already has come from, recommendations from our attendees. And just thank you all to our attendees as well for joining today and for making the time. I know you're all very busy, and I hope you find today interesting, and we'll hope to see you next month. So bye-bye, everybody. Just might move